Venetoclax, which is an oral BCL2 inhibitor, showed a lot of promise in multiple myeloma when they presented the data at ASH a couple of years ago, showing a 40% overall response rate in patients who harbored a translocation 1114 by FISH. So this led to several further studies. The Bellini trial, which you mentioned, was a randomized study for patients with relapsed multiple myeloma who did not have to have a translocation 1114, although many did, comparing venetoclax with bortezomib and dexamethasone versus bortezomib and dexamethasone alone. This study was halted earlier this year when it was discovered that there was an increased risk of death for patients receiving venetoclax and bortezomib as compared with bortezomib and dexamethasone alone. I still think this drug, despite the shortcomings that were seen in the Bellini trial, has an important role to play for patients with relapsed multiple myeloma. In particular, I think we should try to focus on the translocation 1114 patients. That's where we've seen the highest response rates, and data that's going to be presented at EHA this year shows that those patients did not have that substantial increased risk of death, admittedly a subgroup analysis, but maybe suggestive that a biomarker-driven approach might be more appropriate for using venetoclax. Personally, I've treated a couple of patients with venetoclax, most recently a patient with translocation 1114 and plasma cell leukemia who hadn't responded to anything and has responded beautifully to venetoclax as a single agent. So I do think this drug has an important role to play. I think it'll be important to figure out the data and to determine exactly what went on in the Bellini trial. But I think it would be premature to say that this drug does not have a role, because I think it does.